Hi, this is Dr. Jessica Spees at CTA Lab Pathology in Portland, Oregon, and I am continuing our Sunday lecture series on the Lever Dermatopathology textbook chapters. This is the lecture for Sunday, the 17th of January, 2021, and this is Lever chapter 22 on treponemal disease. This chapter mainly concentrates on syphilis and Borrelia infection, including venereal syphilis, non-venereal syphilis, which is Pinto-Yaz and Behel, and on Lyme disease. Today, I'm going to concentrate on histologic examples of the cutaneous manifestations of venereal syphilis, caused by Treponema pallidum, and Lyme disease, caused by Borrelia species. Since this is such a short chapter, I'm also going to throw in a quick run through of some fun cases from my practice this week. Just a few heads up for syphilis. There is quite a bit of explanation in the chapter of subtle histologic differences between the different stages, which I really don't think is important for you to know. The histologic diagnosis depends on finding the spirochete with special stains in the biopsy, but in practice, it also depends in part on clinical suspicion. The clinical suspicion of syphilis, as syphilis can have such a wide range of histologic features and may mimic many other dermatitis on biopsy, kind of similar to how it can mimic different clinical diseases clinically. In our dermpath practice, the majority of the syphilis cases we see are of secondary syphilis, and those are the examples I'm going to show today. The primary lesion of syphilis is often difficult to catch as it heals without treatment within a few weeks and is therefore not often biopsied. A few comments about Lyme disease before we get started. Lyme disease is most common in the North American and European continents, although it has been reported in other parts of the world. In North America, the endemic Borrelia species is Borrelia burgdorferi sensu strictu, which most often presents as erythema chronica migrans, or ECM for short, in the skin. In Europe, the endemic Borrelia species are, in addition to Borrelia burgdorferi sensu strictu, there's Borrelia afzelii and Borrelia guerini. And these species most often present in Europe as erythema chronica migrans, Borrelia lymphocytoma or cutaneous lymphoid hyperplasia or pseudolymphoma are the other terms for that, and acrodermatitis chronica atropicans or ACA. And ACA is due to Borrelia afzelii. And we're just talking cutaneous manifestations here. So let's get going with our cases. And the first case I'm going to show you is of syphilis. This is secondary syphilis, and this is a syphilitic alopecia case. These were scattered 3 to 5 millimeter patches of non-scarring alopecia in a 25-year-old male. They put on their clinical that they considered syphilis, but they thought it was less likely. They thought this was probably alopecia areata. Just to note, up to 7% of secondary syphilis patients have syphilitic alopecia. And it may be patchy or moth-eaten or diffuse or show both patterns of hair loss. In this case, it was patchy. So let's go over the histology for this case, which is really a beautiful example of syphilitic alopecia. The histology is not specific, but it may suggest a diagnosis. You can see here we have the Haut-Vert sections, which Haut-Vert means horizontal and vertical. And so we've got the top of the punch biopsy lopped off here so we can have our conventional sections so we can look at the epidermis. And then we have in the kind of superficial to mid-dermis, we've taken the bottom half of the biopsy and turned it so that we can look at it horizontally and look at all of the hair follicles in the biopsy at once. And then, so here is at the level of the sebaceous glands, the follicles, and here is the subcutaneous. And you can see we're in the scalp, we've got terminal follicles sticking down into the fat. So here, we can see that we have a very low follicular density. Normally in a 4 millimeter punch, we would have probably at least 40 hairs to look at, and we have only a handful here, probably 10 or 12 follicles to look at. So we've got a decreased follicular density. And then a lot of these follicles are in catagen or telogen phase. So this is a catagen telogen follicle, we would say, because it's got this stellate outline. We have another one here. Other things to notice in this biopsy are we have a kind of patchy lymphoplasmacytic infiltrate. And let's go a little bit closer. Let's see, I don't know, this is a little bit blurry. If there's a better section to see this. Here, actually, we can see that the majority of these inflammatory cells are plasma cells. They're the cells with this eccentric nucleus and perinuclear Hoff. That's where the immunoglobulin is stored. So plasma cells are considered a normal component of inflammation in the scalp, and you can see them in lots of different dermatitis on the scalp. But this number of plasma cells is a little bit unusual, and for it to be a predominance of plasma cells is a little bit unusual. So this is a clue in this case to syphilis. It's not specific, but it is a clue. So let's jump to the diagnostic slide. And I just want to point out also that this is a non-scarring alopecia. Syphilitic alopecia is a non-scarring alopecia. The precise mechanism is unknown, but it does resolve with treatment of the underlying syphilis. You can see eosinophils. We don't see that in this biopsy. And you can see a lichenoid or spongiotic tissue reaction pattern, which we don't see here in this biopsy either. You can even see neutrophils in syphilitic alopecia. It can also be non-inflammatory. So let's see, let's go here to our syphilis stain, or our spirochete stain. Actually, this would, is a spirochete stain, which would also highlight the spirochetes of Borrelia. And you can see here we're near the epidermis and the superficial dermis. We've got lots and lots of organisms. Now in syphilitic alopecia, you don't always see organisms. So this is actually fantastic that they're here and we can make the diagnosis. And you can see here there are these, it's hard to see that they're a spiral, but these are the organisms right here, and they kind of have this curved appearance. They can be anywhere. They can be in the epidermis, as this one is kind of difficult to see. It's better seen on the microscope actually, where you can focus up and down. They can be in the dermis. They can be in vessel walls. They can be in the follicle. Actually, here's an organism in the follicle. So again, the features are not entirely specific, and the diagnosis rests on identifying the spirochete or on the clinical appearance if the spirochete isn't present, and the serologic studies. I just want to note that this is an immunohistochemistry chemical stain for spirochetes. In the past, organisms were identified with silver stains and dark field examination, but now we have this much more sensitive method. So the differential diagnosis for syphilitic alopecia is, let's go back to our H&E stain. So we've got a catagen telogen shift here. This isn't, let's see, this is probably 2 out of maybe 10, so 20%. You can see catagen telogen shift in alopecia areata, which is also presents in a patchy fashion clinically, and particularly in subacute alopecia areata, you actually get a very large catagen telogen shift. The tip to distinguish between the two is that in subacute alopecia areata, you will have dramatic follicular miniaturization along with the catagen telogen shift, and you don't see that in syphilis. Clinically, as I said, syphilitic alopecia can be patchy like alopecia areata, but you won't see the exclamation point hairs of alopecia areata and syphilis. Other things to think about in the histologic differential diagnosis, tinea capitis, if you have, which we don't have in this biopsy, but if you have the spongiosis and neutrophils and the epidermis, it can also clinically, tinea can have a moth-eaten pattern. But of course, the PASD stain will reveal tinea. That was done in this biopsy, and that was negative. Other things to think about in the histologic differential diagnosis with a catagen-telogen shift are telogen effluvium, and also clinically, syphilis can present as mimicking telogen effluvium. It can be a diffuse pattern of hair loss. And usually you won't see inflammation in telogen effluvium. If you see inflammation, then there's something else going on, like seborrheic dermatitis or some secondary allopathetic process. But you don't always see inflammation in syphilitic alopecia either. It can be non-inflammatory. And then the last thing I want to mention in the differential diagnosis would be trichotillomania, which can also present clinically as a patchy or moth-eaten alopecia. On histology, you would see a catagen-telogen shift in both trichotillomania and syphilitic alopecia. But in trichotillomania, tips to look for in the histology for the diagnosis would be melanin casts, distorted or cracked hair shafts, signs of trauma to the hair shafts. Okay, so that's it for our first case. Let's go to our second case. Okay, and this was a 63-year-old male in the perianal region. It was an erythematous ulcerated plaque. The clinical differential was ruled out squamous cell carcinoma or condyloma. And this is another lesion of secondary syphilis that we don't see very often. And this is condyloma lata. You can see here that we've got a lot of inflammatory scale crust. We've got lots of serum, lots of neutrophils, parakeratosis. Look at this neutrophilic spongiosis, like you would see in psoriasis. We're here on hair-bearing skin, and this is a hair shaft. You can see there's marked epidermal hyperplasia. Again, lots of inflammation way down here. This neutrophilic spongiosis. There may even be eosinophils. You can appreciate here this cell has a bilobe nucleus with eosinophilic granules in the cytoplasm. Here's another eosinophil. So this is actually the prototypical histology of condyloma lata. It is not entirely specific, but when you see this marked epidermal hyperplasia, marked neutrophilic infiltrate, you think about it. Let's go to the spirochete stain. And this one, as is typical of condyloma lata, is loaded with organisms. And they're really easy to see here. You can see it's hard to see that they're spiraled, but they're these curved spirochetes. You can see they're a little bit coiled here. And in condyloma lata, you mainly see them in the epidermis, although they can be in the dermis. You can see here they're scattered throughout the inflammation in the superficial dermis. Beautiful example here. This was my case, and it was actually my colleague, Steve Poole, that thought of the diagnosis. I was thinking, what is this weird thing that looks like psoriasis and a condyloma at the same time? So condyloma lata actually occurs in about a third of secondary syphilis patients. It's highly infectious, as we can see all these organisms in the biopsy. It may occur outside the genitalia, the umbilicus, mammary folds, axilla. The histology is not entirely specific, as I said before, but this florid epithelial hyperplasia and the parakeratosis with many neutrophils can suggest the diagnosis. Also plasma cells. And let's go actually back and see, there are lots of plasma cells in this biopsy. Here we go, here they are. These eccentric nuclei with the clock face and the perinuclear Hoff filled with immunoglobulin. Again, skin near mucosal surfaces can have plasma cells, but this large number of plasma cells is a little bit unusual. The diagnosis rests on identifying the spirochetes on immunohistochemistry, and it will be present in condyloma lata. The differential diagnosis is condyloma acuminatum, which is caused, of course, as you know, by human papillomavirus or HPV. So for condyloma lata, you would look, for condyloma acuminatum, you would look for koilocytes. And you can see here, we've got a little bit of hypergranulosis. So you might, if you're ignoring the other features in this biopsy, think this might be condyloma acuminatum, but we don't really have the really good perinuclear halos and raisinoid nuclei together of the koilocytes. Also in the differential diagnosis is psoriasis, and it was definitely kind of what I was thinking of when I first looked at this biopsy, because of all this neutrophilic spongiosis. However, in psoriasis, you usually don't get this neutrophilic spongiosis down here. It's usually a little bit higher up in the epidermis towards the stratum granulosum and in the stratum corneum. And you're certainly not going to have spirochetes in it. And then another thing to think about is a fungal or yeast infection, which can perfectly mimic psoriasis with all these neutrophils. And condyloma lata, you wouldn't usually in a yeast or fungal infection get this kind of epidermal hyperplasia though. All right, let's go to the next case. All right, and this is a 68-year-old male with lichenoid papules on the chest. The clinical differential was lichen planus versus lichenoid derogorruption. And you can see here that this is very lichenoid. We've got a dense band-like infiltrate in the superficial dermis, obscuring the epidermal junction. We've got necrotic keratinocytes and colloid bodies here along the dermal epidermal junction. And then if we look at the infiltrate, it's composed of lots of plasma cells. Once again, our perinuclear Hoffs, our clock face nuclei, lots of histiocytes and some lymphocytes. These cells here with the more condensed chromatin that are not plasma cells. And in this particular biopsy, the infiltrate is quite deep. You can see here it's going down around eccrine glands, almost to the bottom of this biopsy. Lots and lots of plasma cells. So of course, we're not on the scalp. We're not near a mucosal surface. We're on the chest. This number of plasma cells is definitely abnormal in this location. And the first thing that you would think about is syphilis. We've got a lichenoid infiltrate that's lymphohistiocytic with lots of plasma cells. And there may be rare eosinophils in secondary syphilis. And here's an example here. So the eosinophils don't exclude the diagnosis. So this is secondary syphilis, and let's go to the spirochete stain. This is another just beautiful spirochete stain immunohistochemistry, and you can see here, just like our condyloma lata, all of these curved spiral organisms, and they can be present anywhere in secondary syphilis, and typically in the epidermis, and also in the dermis, but they can be in the deep dermis. Let's look around and see if we have any. Yes, boy, this is an incredible case, actually. Look at all this. So you can see it in secondary syphilis, the rash of secondary syphilis. I've seen cases where there is much less inflammation. It's very difficult to find the spirochetes. You only find a couple, and you have to spend a lot of time with the spirochete stain looking for them. You don't always have plasma cells. In fact, 25% of cases of secondary syphilis lack plasma cells. In those cases, often the lymphohistiocytic quality of the infiltrate is a clue, especially if you have a lichenoid infiltrate that's lymphohistiocytic. In secondary syphilis, the rash of secondary syphilis, you can get spongiosis, you can get psoriasiform epidermal hyperplasia, you can get frank granuloma formation, especially in older lesions. None of those things we really see here. This is really a more run-of-the-mill lichenoid variant. And the differential diagnosis, let's go back to our H&E. You could think of kind of at low power here. I suppose you could see if you could think of cutaneous lymphoid hyperplasia. It's so dense, but usually the differential diagnosis based on histology is pityriasis rosea, with usually less dense infiltrate than in this biopsy, eczema, psoriasis, drug eruption. Syphilis is the great imitator clinically and histologically. Let's see, let's go to our next case. We're going to move on to Lyme disease now. Because we see so little Lyme disease out here in Oregon, we actually didn't have any bona fide cases in our files. This is an example from Path Presenter, and for those of you who don't know about Path Presenter, it's pathpresenter.net. It's an amazing and free site where you can view slides of various diseases. You can create your own account and library of slides, and I highly recommend this as a study tool for your boards. And it's free, so all you have to do is sign up on the web. So that's what I did today. I signed up because I needed examples of Lyme disease. We're going to start off with erythema chronicum migrans. And as you can see here, actually this is a typical appearance for ECM. The histology is not specific. And actually, not only do we not see it in Oregon very much, but even on the East Coast in the Eastern US, where it's seen a lot more, it's rarely biopsied because the histology is so nonspecific. And as you probably know, the diagnosis is mainly made on clinical grounds, and it's often treated empirically without biopsy. So, but here, let's go and look at this ECM example. You can see there's a superficial and kind of slightly deep, there are a few lymphocytes down here, infiltrate, mostly of lymphocytes. There are not uncommonly, oh, what happened to my focus here? There are not uncommonly eosinophils in ECM, and often plasma cells as well. Actually, this is a pretty different stain from the one we use in our lab. You can tell that there's a lot less pink in it, so there's a lot less eosin, so it's hard to find the eosinophils if there are any in here. And then the plasma cells, I'm not going to get a little higher magnification than this. So it's going to be hard to point out the plasma cells. It's even if you have a biopsy and you know that it's Lyme disease, it's difficult to find the Borrelia in the skin biopsies, even with immunohistochemistry. So in clinically confusing cases where maybe you have a clinical suspicion, but you can't quite make the diagnosis, a combination of tissue culture, PCR for Borrelia on the skin biopsy, and serologic studies can be helpful. Those three things in combination will usually get you the diagnosis. So you can do PCR for Borrelia on these, even if you can't find the organisms on special stains. The differential diagnosis histologically, you might think of, especially if it comes in and is an annular lesion clinically, you might think about erythema annularis centrifugum, could look like this. Histologically can be superficial and deep, perivascular lymphocytes, eosinophils. You might also think about a dermal hypersensitivity reaction, such as to an arthropod bite reaction, to an arthropod bite or drug eruption. Okay, so I think I mentioned everything I wanted to mention there. Let's go to our next case, which is another path presenter case. And this is the cutaneous lymphoid hyperplasia that you can see in association with Borrelia. Other names for cutaneous lymphoid hyperplasia are pseudolymphoma or lymphocytoma cutis. We see pseudolymphoma on a regular basis in our practice, but we don't see Borrelia-associated pseudolymphoma in the US. It's mostly seen in Europe. And our examples in our files of cutaneous lymphoid hyperplasia, not only are they not Borrelia associated, but they don't have these beautiful germinal centers that we see in this particular biopsy. So I couldn't resist showing you this one from Path Presenter. So you can see we have not much epidermal change, and we've got a really dense superficial and deep dermal infiltrate of mostly lymphocytes. I don't know if we're going to get really good high magnification on this. We might have to stay at low magnification. And you can see there are alternating areas where they're blue and this kind of paler, pinker areas. These are the germinal centers. And if we did immunohistochemistry, we would see that the majority of the cells in these blue areas are CD3 positive T cells, and the majority of the cells in the germinal centers are CD20 positive B cells. And in the germinal centers, the B cells will be mixed with smaller numbers of T cells and histiocytes, including tingible body macrophages. As an aside, we always perform immunohistochemistry on these cases because the differential diagnosis on histology is our cutaneous lymphomas, cutaneous marginal zone lymphoma, which is a B-cell lymphoma, and cutaneous follicular center cell lymphoma, which is also a B-cell lymphoma. Cutaneous lymphoid hyperplasia is an antigen-driven process, and when it's caused by Borrelia, it's most often European Borrelia species, as I said before. Let's go to our next case. Similar, but a little bit different. This is actually a marginal zone lymphoma. And like cutaneous lymphoid hyperplasia or lymphocytoma, marginal zone lymphoma is a low-grade, like pseudolymphoma, marginal zone lymphoma is driven by chronic antigen stimulation. It's the lymphoplasmacytic variant, which is most strongly associated with Borrelia, especially European Borrelia species. This is an example of cutaneous marginal zone lymphoma. I'm not sure if it was Borrelia associated or not, but it does show, as opposed to the cutaneous lymphoid hyperplasia, that it's a little less well organized. It's really dense. You can see there are germinal centers here. Are they look a little different than the pale pink germinal centers that we saw in the last example. They're a little bit bluer, and this is from follicular colonization of the follicles by the neoplastic B cells. Again, immunohistochemistry is necessary to make the diagnosis, and the diagnosis rests on identification of lambda or kappa light chain restriction, so monoclonality in these biopsies. You can do immunohistochemistry to look at that, or you can do in situ hybridization. I want to show you, because there were no immunos to go with this particular case, I did want to show you a recent case of cutaneous marginal zone lymphoma we had in our practice. This was not Borrelia associated to my knowledge, but I want to show you the light chain restriction. All right, so you can see somewhat similar to the last case. It's a very dense infiltrate, superficial and deep. And we don't really have great germinal centers like we saw in our cutaneous lymphoid hyperplasia, or even in our last case of marginal zone lymphoma. But we do have this kind of nodular infiltrate, and the majority of these are B cells. Here's the T cell stain. This is actually an example of a T cell rich B cell lymphoma. There are quite a few T cells in this biopsy. You can see they're kind of scattered throughout the nodules. Here's the B cell stain, which highlights many more cells. And here are our nodules of B cells, but also many B cells in between the nodules. Here's a CD21, which is our follicular dendritic cell marker. And it highlights that there are some follicular dendritic cells in these nodules. So these are kind of blown apart follicles, not normal follicles. Here we go, some more here. This is from the colonization of the follicles by the neoplastic B cells. And then let's go down to the lambda and kappa stains. So I'll show you the lambda first, because this is where the money is. And there were many plasma cells in this infiltrate. Sorry, I skipped over that in the H&E section because I knew we were going to see them on the lambda stain. And you can see many, many, many lambda positive plasma cells in this infiltrate. And by contrast, the kappa stain shows next to none, if any. We have just a few. The normal kappa to lambda ratio is 2:1. So we have a flipped ratio, and in this case, a greater than 10:1 ratio lambda to kappa. The flipped ratio alone would really be enough with the other features to make a diagnosis. It doesn't have to be 10:1 lambda to kappa. But if you have a kappa predominant or a kappa light chain expressing marginal zone lymphoma, you want a 10:1 ratio of kappa to lambda. Okay, let's go to our next case, our last path presenter case. This is acrodermatitis chronica atropicans. It's an uncommon late stage Borrelia infection, happens months to years after the initial infection, often accompanied by neurologic symptoms, rheumatologic symptoms, and cardiovascular disease. Again, ACA is associated with the European species of Borrelia, specifically Borrelia afzelii. Patients have high levels of IgG antibodies and can be, and the organism can be identified by PCR in the skin biopsy. So here we have a biopsy of ACA, not specific, but characteristic features of ACA in this biopsy. You can see that we've got epidermal atrophy, not many reedy ridges left here. And the other thing is we have a band-like infiltrate of lymphocytes and plasma cells. I think you might have to the hard to tell. I think some of these are plasma cells with eccentric nuclei. Many of them are plasma cells, actually. You often have dermal edema. And if you did an elastin stain, you would see loss of elastic fibers in the areas of inflammation. The other thing that's characteristic of ACA is loss of adnexal structures. And you can see here, this is the residua of a follicle. Here is a erector pili muscle, but no follicle with it. And we can see this is a pretty big biopsy, and there are no other follicles here except for the very edge of the biopsy. And that is abnormal, loss of follicles in this biopsy. Okay, so that's it for the Lyme disease cases I have to show you. Now I thought it'd be fun just to kind of quickly go through some interesting cases from my practice that I saw just this week. In the first one, this came in as rule-out bullous pemphigoid with a DIF biopsy, and you can see here at low power, we've got an intact epidermis, a subepidermal blister, and it's filled with eosinophils. Here the bilobed nucleus with the eosinophilic granules in the cytoplasm. So they're not the only inflammatory cell in here, but they are by far the predominant inflammatory cell in this subepidermal blister. And here there's some eosinophils even in the epidermis. So we've got a subepidermal vesiculobullous dermatitis with eosinophils. In the subjacent dermis, also lots and lots of eosinophils admixed with some lymphocytes and histiocytes. And then the DIF was positive. Where did it go? Here it is. And so you can see it's kind of ghosted out here, but this is the epidermis, this is the dermis, and this is the linear IgG. The C3 looked the same. Deposition at the dermal epidermal junction or the basement membrane zone. So this is a beautiful example of bullous pemphigoid. All right, the next case I want to show you. A consult case. And this was the neck of a 92-year-old male, excuse me. And you can see at low power here, we've got a nodular infiltrate or tumor actually in the dermis. And at high power, it's composed of an admixture of basaloid cells and cells with sebaceous differentiation. You can see here all these vacuoles in the cytoplasm and the indented nuclei. That's a sebocyte. You can see some of the sebocytes have very large, not small and indented, but very large and indented nuclei with these prominent nucleoli. And when you look at the basaloid cells, they're kind of crowded and overlapping and very pleomorphic. And in other areas, there's tumor necrosis. Let's see here. It's kind of not quite there. This could be considered some tumor necrosis, probably. Let's see if there were other. Here's tumor necrosis with all this pink material, hemorrhage. So even though this is not a very infiltrative pattern histologically, the cytologic atypia, the crowding, there are also many, many mitotic figures. Let's see if we can find some. Here's one. You can see mitotic figures and adnexal tumors, but in combination with these other features, This really is good for sebaceous carcinoma. So don't see that every day. Nice case. This was another case I had this week that came in with a DIF specimen. Actually, this is the biopsy for the DIF. Sorry, it's upside down. And this is when we get a biopsy for DIF, we do a frozen section and stain it with H&E just to make sure that we have what we need to see to make the diagnosis. If we don't have any epidermis, for example, then we're not going to perform the DIF because we're not going to be able to make a diagnosis of vesicular bullous disease, where the diagnosis is going to rest on what's happening at the epidermal junction. So the scalp section looks good. We did the DIF. It was negative. The clinical was an extensive rash. And the clinician thought it could be pemphigus vulgaris, toxic epidermal necrolysis, or Stevens-Johnson syndrome, or bullous pemphigoid. We can see here that we have at low power what looks like an intraepidermal blister. In some areas it looks subepidermal. It's very acute. There's a basket weave stratum corneum. And then if we look closely at what's in the blister, we can see all these acantholytic cells. Some sticking to the basal layer, or some intact basal layer cells still. And look at these cells, acantholytic, and they have this smudgy gray nuclei. Let's see, and sometimes multinucleate here. So this is a beautiful example of a herpetic dermatitis, more smudgy gray nuclei. Actually, what this phenomenon is the chromatin is being marginated to the edge of the nucleus. Here's another multinucleate cell with that smudgy gray appearance. Of course, pemphigus vulgaris is an acantholytic process, but you're not going to get these cytopathic changes of herpes. Whether this is herpes simplex or herpes zoster has to be determined by doing immunostains because they can have identical histology. So that's what I did. I called the clinician. I asked if he wanted them done, and he said yes. Here is the herpes simplex stain, and you can see it's actually a red immunostain. It is completely negative. Here is the herpes zoster stain. Beautiful positivity. Actually, we'll keep this for a control tissue for our lab. Amazing. Look how many cells are staining. All right, next case. All right, so this was, you can see it's an acral skin biopsy, no adnexal structures, and then this compact orthokeratosis, which is normal for acral skin, and hypergranulosis, also normal for acral skin. This is maybe a little bit more stratum corneum than we usually see in the acral biopsies. You can see there's a little bit of inflammation here. I can't tell whether these are neutrophils or lymphocytes. A little bit of parakeratosis probably admixed in there. Again here, oh, many neutrophils. So is this, and a little bit of spongiosis. So is this tinea? Is it eczema? This actually came in as rule out scabies. And you can see here are the pigtails of scabies. These are part of the exoskeleton of the scabies. And you can see they can look a little bit like keratin fragments, but they have this a little bit different quality to them. Let's go to the next sections, and I think we'll have the entire scabies organism to see. Yep, in the red circle. More of it anyway. A lot more of it. You can see some of it. These are Pittosporum, I think, admixed in here. Here we go. Here's more of the entire portion. And this is the gut here. So scabetic dermatitis, beautiful. We don't always get to see this. I've seen it with no inflammation. I've seen it when I've leveled through the block, and it's been on the very last section with hardly any of the tissue left. All right, next case. All right. So this case came in as rule-out morphia scleroderma, and that's exactly what it is. This is a beautiful example of it. So many times we get sent cases to rule out morphia scleroderma, and we're really wringing our hands because we can't find the changes, or the changes are so subtle. But this is a really textbook example. And typically in the early stages, you see inflammation, superficial and deep perivascular lymphoplasmacytic, often with eosinophils. Here we have, this is probably a plasma cell right here with the eccentric nucleus and a few lymphocytes. We don't have much inflammation left. We've got all these melanophages. And then here, this is on severely sun-damaged skin. This is also elastosis. Here in the mid to deep dermis, we've got this smudgy, homogenized looking collagen, thickened collagen bundles. And at the junction with subcutis, we have this flattened interface. And then at low power, we have what we call the cookie cutter sign. So this is beautiful morphia scleroderma. Next case. And this case came in as rule out cyst or lipoma on the forearm of somebody with a history of a relatively thick melanoma back in 2016. This is 2020, and he presents with this nodule in the deep dermis. And you can see there isn't a whole lot of melanin in here, but this is metastatic melanoma. You can see these epithelioid cells and these confluent nests and sheets. No melanin. Actually, this was completely amelanotic. This almost looks like a Hodgkin cell here with these two nuclei facing each other with the big nucleoli. Look at the pleomorphism of these cells and the huge nucleoli. So even though I thought this was probably melanoma based on these features and the history, I got a melanase stain. You could have done a SOX10 stain or an HMB45 stain or an S100 stain. And here's the melanase, which stains the melanosomes and the cytoplasm, and it's beautifully positive. So metastatic melanoma. And this case actually was just a few cases later in the day. I thought so. And this was a non-healing ulcer biopsied by a podiatrist that was 5 centimeters in diameter on the heel of an older male patient. He actually did a 2 millimeter by 1 centimeter deep biopsy, which is why this punch biopsy looks so unusual. You can see that it's completely ulcerated. There's no epidermis left. All this pink stuff is fibrin. And then here is this infiltrate of, similar to the last case, very pleomorphic cells. Hard to see big nucleoli in these. Actually, let's go over to this area. And smaller nucleoli than in the last one. But some of the cells do have melanin pigment in them down here. There are also some melanophages admixed. As I recall, this tumor had quite a mitotic rate. I'm trying to find mitotic figures. Here they are, I circled them. So here's one, another one. This is melanoma. And actually, because there was melanin pigment, I didn't do any special stains. I thought this was good enough for diagnosis, and I had a colleague concur with me. I think I have one or two more cases. And this came in from a clinician who was very good as rule out pityriasis lichenoides chronica. And actually I looked at the slide before I looked at the paperwork, and I thought, this is pityriasis lichenoides. This is a beautiful example of it. You can see here it's relatively acute because there's a basket weave stratum corneum overlying this layer of parakeratosis. And then you've got a lichenoid interface reaction with some dead and dying keratinocytes here, a band-like infiltrate of lymphocytes. There should be no eosinophils. If you find eosinophils, think about another diagnosis. And then many people put pityriasis lichenoides in the lymphocytic vasculitis category because there is more often than not purpura or extravasated red blood cells, which we have a beautiful example of here. So the triad of histologic features you want to see in pityriasis lichenoides is the interface with the lymphocytic vasculitis, quote unquote, and the parakeratosis. And you can have neutrophils in the parakeratosis, which I think we might have a couple here. And there's often a deep extension of the infiltrate in the dermis, which we have here. So it kind of has a wedge shape. Other things you want to think about in pityriasis lichenoides, you want to look for atypical lymphocytes and make sure that this isn't a CD30 positive lymphoproliferative disorder, excuse me. There can be scattered kind of larger lymphocytes and some histiocytes. You can see here this kind of kidney bean shaped nucleus with the delicate chromatin and the little tiny nucleus, nucleolus, sorry, it's a histiocyte. But we shouldn't see really a lot of large atypical lymphocytes, and you want to start thinking about a CD30 positive lymphoproliferative disorder. Okay, so two or three more cases, actually. Kind of related to a previous case we saw, similar but different. This is on the cheek of an older male patient, as I recall. And you can see there's a nodular infiltrate, multinodular, you could say, of blue cells and cells with this vacuolated cytoplasm. A lot of these vacuoles don't have the kind of fine vacuoles of sebocytes, but when you start looking around, these are sebocytes. And then in other areas, there are what look like ducts being formed. And in contrast to our previous case, we don't really have the crowding, high mitotic rate, kind of overlapping nuclei. In this, you can see the cells look more monomorphic, the basaloid cell population. This is a sebaceoma, old term for it, sebaceous epithelioma. I think most people use the term sebaceoma now. Yeah, it was a beautiful case. We put this in our study set. Next case. This is a skin shave biopsy on the scalp of an older male. You can see here that in the epidermis, in the stratum corneum, we have a little bit of parakeratosis. In the epidermis, a lot of the keratinocytes are kind of enlarged with abundant pink cytoplasm as composed to the normal keratinocytes around this eccrine coil. So we have what Ackerman used to call the boy-girl sign. So pink, blue, pink in the stratum corneum. You also see that in the epidermis, pink, blue, pink, the boy-girl sign. So that's an actinic keratosis. And then what's going on here in the dermis? We've got all these spindled cells and some admixed with some inflammation. Some of them are quite large. Some of them are quite hyperchromatic. Let's look around here. This is even better down here. See, look how pleomorphic these spindled cells are from one nucleus to the next. And I was looking for mitotic figures. I believe there are some. Oh, here's a beautiful one. Really atypical mitotic figure in that enormous cell. So the differential diagnosis is atypical fibroxanthoma, or AFX. You don't you can see actinic keratosis over AFX. Spindle cell squamous cell carcinoma and spindle cell melanoma would be the top three in the diagnosis here. You might also think about leiomyosarcoma. These kind of are forming fascicles, if you use your imagination here. So in order to make the diagnosis here, we have to do immunostains. I did a SOX10. You can see here normal numbers of epidermal melanocytes, and the SOX10 is not staining the lesional spindled cells. So unlikely to be melanoma. I have seen very, very rare cases of spindle cell melanoma that are SOX10 negative, but that is really the exception to the rule. And you usually will see some other clue, like a little bit of melanoma in situ off to the side. Here's a keratin 5/6. You can use other keratin stains. This is really considered the best one for this differential diagnosis. And you can see our spindle cells are staining. So this is not melanoma because it's keratin positive, and this is not AFX because it's keratin positive. This is a spindle cell squamous cell carcinoma arising in this actinic keratosis. All right, last case. Turn it around. And this is a bisected punch biopsy. This came in as rule out. I can't remember. It was an itchy rash is what I remember. And you can see here, we don't have much going on in the epidermis in these first sections. Got a little bit of inflammation here and perivascular distribution. And then what's this down here? We've got a mixture of neutrophils and histiocytes. So sometimes deeper level sections are the best special stain. And on the deeper level sections, you can see an altered follicle comes up. Here's that area. Even more neutrophils are coming up in that focus that we saw in the initial level sections. And let's see here on the deepers. This really blows up into a full-blown suppurative folliculitis with a ruptured follicle, extravasated follicular contents here. And in the center, many pityrosporum yeast. The gram stain was negative. Here's the top of that follicle. And so I know not everyone believes in pityrosporum folliculitis, but that's what I think this is. Here's the PASD stain, although we didn't need it to see the pityrosporum. Here they are highlighted by the PAS stain. Here's the budding yeast. Okay, so that's it. Thanks for tuning in. We'll see you next week. Hope you enjoyed the extra cases, and thanks a lot.